Hello and welcome. We're about to take a deep dive into the incredibly high-stakes world of acute ischemic stroke management. Together, we're going to follow the entire clinical path, from the initial diagnosis all the way to long-term prevention, really digging into the critical, evidence-based decisions that shape modern stroke care. Let's get started.
So, let's start with this classic, quintessential clinical problem, the wake-up stroke. You know the scenario. A patient goes to bed fine, wakes up with a deficit, and nobody knows when it started. Historically, these patients were just out of luck for time-sensitive therapies. But it's this exact question that has really sparked a revolution in how we think about stroke, pushing us way beyond a simple wall clock and into the actual physiology of the brain itself.
So, here's our roadmap. We're going to follow a really logical clinical path. First up, diagnosis, and we'll introduce this game-changing idea of the tissue clock. Then, we'll get into the two main pillars of reperfusion therapy. After that, we'll navigate the tricky aftermath and potential complications. And finally, we'll play detective, investigating the root cause of the stroke and laying out the best strategies for long-term prevention.
Okay, Section 1. This part is all about what I think is the single most important paradigm shift in modern stroke care. And that's the move away from these rigid, absolute time windows towards a much smarter, tissue-based approach that's guided by advanced neuroimaging.
You know, the entire goal of acute stroke therapy really boils down to this one thing: rescuing the ischemic penumbra. Think of it like this. You've got a core of dead tissue, but surrounding it is this area of brain that's, well, it's at risk. The blood flow has dropped so low that it can't function properly, which is why the patient has symptoms, but it's just high enough that the cells haven't died yet. It's stunned, not dead. And this is the tissue we're in a race to save.
And to actually see this race playing out, we turn to specific MRI sequences. Now, what's so fascinating is how these different pictures change over different timelines. You have diffusion-weighted imaging, or DWI, which lights up bright within minutes. It's showing us cytotoxic edema, basically water getting trapped inside swelling cells. And we confirm that with a corresponding dark spot on the ADC map. But here's the kicker. The flare sequence, which shows us a different kind of edema, well, it doesn't turn bright until about 4.5 hours have passed. And that critical time gap, well, that's the key to our whole tissue clock concept.
And here's where we put it all together in practice. It's called the DWI flare mismatch. It's actually pretty simple. If the stroke lesion is bright on DWI, but it's still dark on flare, we can be pretty confident that the stroke is less than 4.5 hours old. And that means the patient is a candidate for IV thrombolysis or clot-busting drugs. This whole idea was proven in the wake-up trial, and it totally changed the game. It lets us treat those wake-up stroke patients based on what the tissue is telling us, not what the clock on the wall says. We're treating the brain, not the time of onset.
So that brings us right into our second section, the actual intervention. Once we've used our tissue clock to find a patient with salvageable brain, our one and only goal is reperfusion, getting that blood flow back. And we do that with two main pillars: intravenous thrombolysis and endovascular thrombectomy.
All right, for thrombolysis, dissolving the clot with medicine, we have two main players. Alteplase has been the old gold standard for years, but honestly, tenecteplase, or TNK, is quickly taking over. And you can see why, right? It's just so much more practical. TNK is a single, quick IV push. Alteplase is a bolus, then a whole 1-hour infusion. Plus, TNK has a longer half-life and it's better at targeting fibrin in the clot. That speed and simplicity make a huge difference, especially in drip and ship situations where you treat a patient at a smaller hospital before flying them to a major stroke center.
Now, for the really big clots, what we call large vessel occlusions or LVOs, just using medicine often isn't going to cut it. This is where mechanical thrombectomy comes in. It is the definitive treatment. It's a procedure where we literally go in through the blood vessels and pull the clot out. And what's absolutely incredible is that the landmark DAWN and DEFUSE 3 trials completely changed our thinking here, showing a massive benefit for up to 24 hours after onset, as long as advanced imaging shows there's still a good amount of salvageable brain tissue.
The procedure itself is it's an elegant piece of work. First, the neurointerventionalist gets access, usually in the groin or wrist, and threads a tiny catheter all the way up into the brain. Sometimes they'll deploy a tiny little filter basket past the clot to catch any pieces that might break off. Then the main event, a stent retriever, which looks like a little mesh tube, is opened up inside the clot. It grabs on and the whole thing is carefully pulled out. Afterwards, success is graded on what's called the TI-CI scale. A TI-CI3 means perfect reperfusion. That's the home run.
But you know, just opening up the artery, that's really only half the battle. Now we enter this incredibly critical post-intervention phase. Our focus shifts to anticipating and managing the major complications that can happen, all to protect that brain tissue we just worked so hard to save.
The complication we all fear the most is hemorrhagic transformation. This can happen when you restore blood flow to an area where the blood vessels are already damaged and leaky from the stroke. The ECAS-2 criteria help us classify how bad it is. So an HI1 or HI2 are just tiny specks of blood, and they're usually no big deal clinically. But a PH2, that's a large hematoma that's swelling and pushing on the brain. And that is a neurological catastrophe.
After a big stroke, you're pretty much guaranteed to get some brain swelling or edema, but it is absolutely critical to know what kind of edema you're dealing with. The swelling we see in stroke is mostly cytotoxic edema. It's caused by the energy pumps in the cells failing. This is totally different from the vasogenic edema you might see around a brain tumor, which is from a leaky blood-brain barrier. And here's the clinical pearl. Cytotoxic edema does not respond to steroids. That's a classic mistake. The real treatment relies on things like osmotic therapy.
And our entire strategy for managing brain swelling is based on a fundamental rule of neurocritical care, the Monro-Kelly doctrine. Just think of the skull as a rigid sealed box. Inside, you have three things: brain, blood, and cerebral spinal fluid. If one of those things gets bigger, like a swollen edematous brain, something else has to get smaller to make room. When that compensation system fails, the pressure inside the skull just skyrockets. And that pressure has a direct impact on blood flow. It all comes down to this simple but brutal equation. The cerebral perfusion pressure, which is the force pushing blood into the brain, is your mean arterial pressure minus your intracranial pressure. So as that ICP rises from the swelling, your CPP starts to plummet. And that puts the fragile penumbra at risk of a second ischemic hit. So our main goal in the ICU is to do whatever it takes to keep that CPP in a safe range, usually somewhere between 60 and 70.
Okay, so once the patient is stabilized and out of immediate danger, our whole focus pivots. We move from acute crisis management to long-term prevention. And that always starts with a meticulous investigation to figure out why the stroke happened in the first place. So now, we become detectives.
One of the biggest culprits is a cardioembolic stroke, which is when a clot forms in the heart and then travels up to the brain. And the number one cause, by a huge margin, is atrial fibrillation. But you always have to keep these other high-risk sources in mind, like mechanical heart valves, a big heart attack that left a clot on the wall of the heart, or even vegetations on the heart valves from an infection like endocarditis.
Now, when we talk about AFib, there is a super important distinction you have to make that completely changes how you treat the patient. You have to separate valvular from non-valvular AFib. The modern definition of valvular AFib is actually really specific. It's only AFib in someone who has either a mechanical heart valve or moderate to severe mitral stenosis. That's it. And those patients must be on warfarin. Pretty much every other type of AFib is considered non-valvular, and for them, the newer direct oral anticoagulants, or DIACs, are the first-line choice.
Another major cause of stroke is something called intracranial atherosclerotic disease, or ICAD. This is plaque building up in the arteries inside the brain itself. Now, the key takeaway here, and it's a big one, comes from the Sampras trial. It was a landmark study that showed for most of these patients, aggressive medical therapy, pills, not procedures, is actually better than putting in a stent, mainly because the risks of the stenting procedure were just too high.
And that brings us perfectly into our final section, which is all about the long-term game plan. We're talking about the specific medical and surgical strategies we use for secondary prevention, all tailored to exactly what caused the stroke in the first place.
So for those atherosclerotic strokes we were just talking about, the cornerstone of prevention is what we call aggressive medical therapy. It's really a three-pronged attack. First, antiplatelets. Sometimes we even use two of them, like aspirin and clopidogrel, for a short time after a minor stroke. Second, a high-intensity statin, and we are serious about getting that LDL cholesterol down below 70. And third, really tight, long-term blood pressure control.
Now, if the plaque buildup is in the carotid artery in the neck, we have a couple of options. The classic procedure is a carotid endarterectomy, where a surgeon literally opens the artery and scrapes out the plaque. It's still the gold standard for a lot of patients. The alternative is carotid artery stenting, which is a less invasive option. The choice really depends on the patient. For someone who's had neck surgery or radiation before, or is just a high surgical risk, stenting might be better, even though it does carry a slightly higher risk of causing a small stroke during the procedure itself.
So, we end up right back where we started, but now with a completely different way of looking at things. The story of modern stroke care is this relentless march away from the wall clock and towards the tissue clock. We've moved from rigid time windows to individualized physiological assessments. And that leaves us with this final, really interesting question to think about. If the penumbra is our new clock and perfusion imaging is our new guide, what role, if any, will simple time-based rules play in the future of how we manage acute stroke?